You will not force.
Thank you very much, and I hope you enjoy my talk. Should we put the lights down slightly? Yeah. So there's really one main theme of this talk, and that's a new therapy called dorsal root ganglion stimulation. And dorsal root ganglion stimulation is something which is really in its infancy. It only came to the UK. We were one of the first centres to perform the technique in 2013, and it had only really been going for about a year or two before that in mainland Europe. So for us, this has been a journey of discovery, and both in terms of the clinical effect of DRG stimulation, quite a big learning curve in terms of getting it to work for pain, and also applying some of our research. So today I'm going to talk about the clinical effects, what we can use it for, and also some of the research that we're doing using it. So, what is the dorsal root ganglion? Well, the dorsal root ganglion is a structure, it's a swelling in the afferent nerve root, or the nerve root, just outside the spine. So it's underneath, typically just underneath the pedicle, so that's the pedicle of the vertebral body, which joins the vertebral body to the posterior elements of the spine, and the dorsal root ganglion sits just under there, and there's a ventral and a dorsal root, as you can see here, and it contains the cell bodies from the pain fibers, so the C fibers, and also other fibers coming from the periphery. And as you'll see later on in my talk, it's also important in terms of autonomic control as well, and not much is known about that, so that's one of the things that we're looking at the moment. There's a little bit of cerebrospinal fluid around it, but you can see that the DRG really, the dural sac here terminates just around about the level of the DRG or slightly beyond it. But what this means is that you can access the DRG quite nicely from within the spinal canal in the epidural space. So you can come into the epidural space and access it that way, which is much easier than from the outside. And you can do that with minimally invasive techniques. Now, we know that the DRG is very important in pain. When you have neuropathic pain, so that's pain that's caused by damage to the nervous system. So if, for example, you cut a nerve, the injury may heal, but you have ongoing severe pain in, for example, your foot or your arm, you get abnormal discharge from primary sensory neurons in the DRG, and you get increase of certain neurotransmitters. There's also this is thought to be largely due to a pro-inflammatory reaction as a result of the damage. And because of this, you get alterations in the firing of these nerves, and the nerves actually fire spontaneously, and that's probably what sets up neuropathic pain. So you have the damage, the nerve then becomes abnormal, and then the C fibers or the pain fibers fire when they shouldn't be firing, basically. So you experience pain even though the initial injury has gone away. And this has been shown electrophysiologically that the important thing about the DRG is it acts as a sort of T-junction. So here you have impulses coming in from the peripheral nerves, so for example your feet or your arms or wherever, and there is this T branch here going into the DRG acts as a sort of filtering device for signals. So depending on what happens in this DRG in the electrical box there, you get some filtering of what happens to the impulses that are going into your spinal cord. So for example, if you stimulate this, this would be a normal reaction. So you cause some stimulation in the axon, in the peripheral nerve, and then you get big discharges in the nerve going into the spinal cord, in other words, the dorsal horn nerves. If you stimulate for a period of time, what happens is it massively reduces the frequency of that firing, and certain types of stimulation you can reduce the amplitude of that firing. So we know electrophysiologically that you can alter those impulses going into the spinal cord by stimulating the dorsal root ganglion. The other great thing about the DRG compared to other types of neuromodulation for pain, so that our classical type of neuromodulation is called spinal cord stimulation. And with spinal cord stimulation, what we do is we put an electrode over the back of the spinal cord, over the dorsal columns, a little bit higher up. And the aim of that is to stimulate the dorsal columns and produce paresthesia, or strange sensations which block the pain. So if you believe in the gate control theory of pain, that would be the mechanism. The advantage of the DRG is that it's much more specific. So, for example, if you have pain in your L4 distribution, lateral side of your right leg, you can stimulate just the L4 DRG, and you can get your paresthesia and you can get your stimulation effects just in that dermatome. So you don't have any side effects in terms of the rest of your leg. So it's much more specific. And it generally tends to be fairly well mapped. I'll show you. So this is just a little video just to show how it's done. So how do we put the electrode in? So what we do is we do an epidural puncture. So we put the epidural needle in. I'll show you a proper video of us actually doing it in a second. And the electrode has 4 contacts at the end. It's flexible, and it fits into this sheath here, and the sheath is curved. So what you do is you put that through the epidural needle, so you're in the epidural space, and then you can feed, under X-ray control, you can feed that electrode over the top of the DRG, which is the bit that you want to stimulate. You then remove the sheath. You can then stimulate in theatre to see if it's having an effect on the pain, so you do it with the patient awake, and then you remove the sheath, you remove the needle, and then you connect the rest of it to the battery or the implantable pulse generator, which you can place anywhere under the skin. So we would put it in the buttock or under the ribs or in the abdomen. So you can put that anywhere. So we'll just go on to it. So what's our experience with this since 2013? And we've been using this to treat pain. Let me just show you, this is my colleague, James Fitzgerald, performing a procedure here. So what you can see here is, this is the L5 vertebral body. This is the intralaminar space. So there's the lamina of L4 and the lamina of L5 here. And in between here you have the ligamentum flavum. And what you're trying to do is you're trying to put your epidural needle, advancing it so that you get it just in the midline, as close to the midline as you possibly can. And the angle here is fairly critical. And what you're aiming for is the pedicle of L4 on the left side in this patient. So you know that the DRG is going to be sitting just underneath this pedicle. So you get the needle into the right place. This is sometimes takes a bit of... so that one's too far over. So if you get it in there, you're not going to be able to steer your electrode up to the L4 DRG. So now he's replaced it in a much better position, so that it's just around about the midline, or just over the midline. He then has to get into the epidural space. So this is a very, very classic anaesthetic technique using loss of resistance. So you know that when you're in the ligament, you can't inject fluid, and as soon as you go through, the fluid goes through very easily. And hopefully at this point you don't get CSF. If you do, then it's not a big disaster. You can just withdraw the needle slightly. Then you can check that you're in the right place with a guide wire if you so wish. And here you can see he's happy with the guide. He's not quite in, so he's just going to push it in a little bit further. We'll just fast forward this slightly. And this is the sheath here. So what you can see is this is the sheath with the electrode inside it, and there's a little port here that tells you which direction it's in, and also you can use to lubricate the wire. So we push that through into the epidural needle, and you'll see it coming up on the X-ray in a moment. Here you can see it just in the epidural space. There's 2 contacts out of the 4 that are in the epidural space there. So the next thing to do is to steer it in here. I think at this point the patient's awake and is just requiring a little bit more sedation because he's a bit uncomfortable. So he's just waiting for the anaesthetist to give him a little bit more, and then we'll just fast forward it a little bit. And here you can see him pushing the electrode, and what he's doing is he's aiming for the bottom of this pedicle here. So he's sort of knocking at the door. He's a little bit high. There it is. So it's gone through. There's some very tight ligaments around the entrance to the exit foramen that can be quite difficult to get through, and this often stops the electrode. So you have to just fiddle with it until it gets through. And you can use a guide wire to push it through if you can't get the electrode through. And he's aimed to get the second or one of these two electrodes over the DRG. And when that's in place, he'll then remove the sheath. We'll just speed that up. So he's removed the sheath, and then he's going to put a little loop in the wire. This is technically quite a difficult thing. This took us quite a long time to learn. So it's a little bit more difficult than the standard spinal cord stimulation. Just speed it up a little bit. And this is the loop here, which is a relieving loop to stop it from falling out. And then you can do a lateral view, and you can show that your electrodes are right at the top of the dorsal, at the exit foramen, which implies that they're in the dorsal part. So if you get your electrodes in the ventral part, then you get ventral stimulation, which causes motor side effects, and you don't get pain relief. So it's very important to get the electrodes in the dorsal part. So we did an initial study, which was a multi-center study, which is about to be published. But I'm going to tell you about the 28 patients that we enrolled in this center, because I have the data for those. So it was 60 patients altogether, but 28 from Oxford. This was just simply an observational study looking at pain scores. It wasn't randomized as such. The primary outcome measure was pain relief at the exit, at 24 months, compared to preoperatively. So out of those 28 patients, one failed the trial. 2 subjects exited at study completion, so I don't have follow-up on those. The mean follow-up, 7.9 months. And these are the patients that we've treated. So we have a number of patients with lower limb complex regional pain syndrome. So these are people who have had injuries, often quite a minor injury with severe neuropathic pain resulting, and they often get red, swollen limbs. It's a very classic symptomatology. We have some patients with lower limb trauma with peripheral nerves. So we've got a patient with a couple of patients who've had ankle fractures and had ongoing pain despite fusion. We've got quite a few patients with groin and testicular pain. And the most common out of these, so we've done 150 patients now, about 15 to 20 of our patients are patients who've had hernia repair. So hernia repair, post-operative neuropathic pain is relatively common, probably about 20%. Most of those patients can be managed with painkillers, but in some of them it's refractory, and those are very good candidates for DRG stimulation. So if you have post-hernia pain patients, we're very happy to see them. They do very well with L1 and L2 stimulation of the DRG. We also have patients who have had knee replacements. In fact, that seems to be a growing number. So 15% of patients with total knee replacements will have a worsening of their pain, which is possibly neuropathic in nature, and they do very well with L3 or L4 stimulation. So that's another group. If you have patients with post-knee replacement pain, we're also happy to see them. And we have patients with phantom pain, so post-vascular surgery or trauma. We've got some soldiers from Afghanistan who've had their legs blown off, and they've done quite well with this as well. And just to give you some idea of the variability in response, out of the 25 patients that I've got here, some of them have had complete pain relief, and there are 1 or 2 of them who have not had pain relief, but the majority of them have had significant pain relief. So mean improvement of almost 66%. And you've got to remember that this is a very refractory group. So these are patients who have tried all classes of neuropathic pain drugs, gabapentin, morphine. A lot of them are on morphine, other analgesics. They've tried alternative therapies. Some of them have tried cognitive behavioral therapy. Some of them have even tried spinal cord stimulation with no effect. And it leads to a very significant improvement in quality of life, as you can see here. So this is our patient satisfaction score, a very simple score, but quite useful. And as you can see, that 18 out of 25 patients were in the better or much better category. And 7 patients said there were no change in terms of subject satisfaction. Complications, in this group of 25, we've had 3 that have required reposition of the IPG. And I think that's a learning point for us, because when we first started doing this, we put a lot of the IPGs in the buttock, which is fine for some patients, but some patients find it quite uncomfortable, and we've changed our practice there. Lead migration is still an issue, especially at the L4 and L5 levels. There's about a 3 or 4% migration rate, because despite the fact that you put a relieving loop in, it can still fall out. And lead position in a couple of patients, so we've had to reposition them. If we look at different regions of pain, the light colour is the lower limb pain, and this is the numerical rating score of pain. So 10 is the worst possible pain you can imagine, and 0 is nothing. So at baseline, most of them are at around about 8 or above, and at the 12-month score, they're roughly about half. And it doesn't seem to matter whether it's thoracic pain, lower limb pain. I don't have upper limb pain in here, but the upper limb pain is similar. Different types of, we don't have huge group numbers in each group, so I've just distilled out some of the main ones. So CRPS, they seem to be similar responder rates, so roughly about 50% pain relief in most groups. Actually, some of the non-CRPS groups seem to have a better responder rate. So this one would include the hernia repairs, for example. So if you're looking for proper evidence, there has been a randomized controlled trial. So this was an FDA-approved trial in the US. So it was very interesting historically what happened with DRG stimulation. It was invented by the Americans, but they couldn't use it because they didn't have FDA approval, and they couldn't get funding for a trial. So they got the Europeans to use it here. We then developed it, got the initial studies going, and then they went back and got FDA approval for a trial. So what they did is they compared it to the standard spinal cord stimulation. So this is SCS, and this is the DRG. So for patients who would be suitable for both, and the primary endpoint, patients had to meet 3 criteria. More than 50% of pain relief in the primary area of pain, and freedom from neurological deficit at 3 months, so in other words, they didn't have any weakness. There were 60 in the DRG group who were compared to 54 in the control, so there were a few that didn't get through to the implant stage. 0 neurological deficit in both groups. Serious adverse events includes things like hospitalization to sort out a problem. So most infections would be included in that, and that was similar in both groups. Device-related adverse events would include things like having to reposition a lead or an IPG, or replace a bit of kit because it wasn't working. And again, that was similar in both groups. So it's about 20%. So it's got quite a high device-related adverse event rate, but that's similar in all neuromodulation, really. But this is the most important thing, and that is that patients with DRG stimulation get, on average, just over 80% pain relief. Over 50%. 80% of patients get over 50% pain relief or more, compared to spinal cord stimulation, which was about 56%. So spinal cord stimulation is a very effective treatment in certain pain conditions, but DRG stimulation in these patients seemed to be even better. And this trial was powered as a non-inferiority trial, but actually was designed to show superiority as well, and it was shown to be superior. And again, we're always interested in quality of life, and you can see big improvements in quality of life in both groups, but in DRG compared to control is even better. So the mainstream indications, there's variable evidence for the different groups, but the mainstream indications are patients who've had hernia pain, post-joint replacement, radicular pain after lumbar surgery is another one, where someone has a very specific focal pain related to a nerve root, CRPS, type 1 and 2, phantom limb pain. These are the big groups. Actually, there are many other pains people that we have tried. For example, this was a case report that was written by one of my medical students. We had a lady with severe pelvic girdle pain. She'd had pain for years after her third pregnancy. So she'd had pelvic girdle pain since the first pregnancy, which improved a bit after each one. And then after the third one, it never got better for about 5 or 6 years. And she was housebound with the pain. She couldn't get out of bed. She was on morphine. She had 2 young children that she had to rely on her husband to look after completely. And we took a punt and we tried L1 and L2 stimulation. And she got extremely good pain relief, about 60 to 70% pain relief, and is now walking around looking after her children. She's not pain-free, but she's much better. So if there are any gynecologists in the room or obstetricians, we're also interested in those as well. So the title of my talk was about side effects. So what's this got to do with side effects? Well, what is a side effect? If you look in the dictionary, it says a secondary, and I've highlighted the word typically, undesirable effect of a drug or medical treatment. And there are numerous examples of this in the literature. Viagra is obviously the one that everyone knows about, originally introduced for hypertension and heart problems, turned out not to be so good for those, but quite good for other things. Thalidomide, not very good for morning sickness, but very good for leprosy and for chemotherapy and certain types of cancer, and many, many other drugs. And the most recent one that's hit the news is the Zika virus. Because we know that the Zika virus kills stem cells in the developing brain, there are a couple of trials that have just started of using Zika virus to try and treat glioblastoma in the brain. So I've told some of my neuro-oncological colleagues that they need to start looking for another job quick, because if it's successful, their surgery will be not so relevant. Now I'm going to go on to a little bit of a tangent now, just to explain why we're looking at side effects. So we've been practicing deep brain stimulation, myself and Tipu and James, for a number of years. And one of the things that we originally looked at many years ago was the effects of stimulating the brain on the cardiovascular system. So with deep brain stimulation, it's similar in terms to most neuromodulation. We put an electrode into the brain, to an active part of the brain, and then we stimulate it to try and either increase or decrease the activity of that part of the brain. And the most common thing we do that is for Parkinson's disease, but we also do it for chronic pain. And these are electrodes in the periventricular area and the sensory thalamus, and these are electrodes in the anterior cingulate cortex. And these can be quite efficacious areas for treating chronic pain. So when your DRG or your spinal cord stimulation doesn't work, or if you have face pain, which is too high, or post-stroke pain, you can put electrodes into the brain and stimulate it to improve pain. Now, many years ago, we started looking at the effects of deep brain stimulation on blood pressure. And this is just some examples to show that when the stimulation is turned on, you can either increase blood pressure, and then when you turn it off, it comes back again. This is periaqueductal grey. Or you can decrease blood pressure with stimulation. This is just a composite graph to show a number of patients who fit into each group. And they either fit into one group or the other. And the reason for that is that if you look at where the electrodes are, these are the electrodes that reduce blood pressure, and these are the electrodes that increase blood pressure. And you can see that the ones that increase blood pressure are a bit more dorsal. And that's because it's stimulating the dorsal part of the PAG, which has been shown in animals to increase the fight and flight reaction. So we thought we'd put 2 and 2 together. We'd looked at cardiovascular side effects of deep brain stimulation. So what about DRG stimulation? The interesting thing about the DRG, and it's been shown in rats, that there is a certain amount of autonomic coupling between the C fibers and the autonomic fibers in the DRG. So if you stimulate the C fibers, can you change the autonomic nervous system? And in actual fact, we know that the autonomic nervous system is important in pain. So for example, you have in CRPS, you have a sympathetically mediated pain where you have increased sympathetic activity. And we know that these patients do well with DRG stimulation. So is that the DRG stimulation on the C fibers, or are we actually altering autonomic activity? And so that's what we set out to look for. So our hypothesis was that we would be able to alter sympathetic nerve activity using DRG stimulation at certain levels. So how do we measure that? This is Ursa, who's one of our research assistants, and we got some funding for a project for her to look at this. And what she does is she puts a microelectrode into the perineal muscle and finds a sympathetic nerve, which is more difficult than it sounds, actually. So you have to put a very, very thin electrode into the leg. You can't really feel it. It's sometimes a little bit sore afterwards. And there are three types of fibers, basically: motor, sensory, and autonomic. Motor, you know when you've got that because the foot twitches. Sensory, you know because you can rub the back of the foot and you'll see lots of electrical activity. And the autonomic nerves have a very characteristic waveform. So when you're an expert, you can see when you're in an autonomic nerve. And you can measure other things at the same time. So you can measure skin sympathetic activity, you can measure continuous blood pressure, ECG, all these sorts of things, and you can measure the pain. And these are just some examples of recordings that we did when we were looking at deep brain stimulation in the PAG, and we took the dorsal and the ventral targets that I spoke about a minute ago. And what we showed was that if you stimulate the dorsal target and you get an increase in blood pressure. So here you can see when stimulation is turned on, there is an increase in blood pressure. You can look at the sympathetic nerve activity and you can see some changes, although not huge changes in that particular patient. But here we've got an example of someone who has ventral PAG stimulation, and you can see when it's turned on, the blood pressure drops, and the MSNA is counted in bursts per minute, drops from 24 to 16. So we know we can stimulate the brain and reduce or increase sympathetic activity. So what happens when we stimulate the DRG? So our two hypotheses: one is that we could change sympathetic nerve activity. The second is that this is related to pain relief in some way. And we showed that one of those was correct and the other was wrong, and I'll show you in a minute. So this is just an example of a patient with DRG stimulation with a burst frequency of 40 per minute and off, i.e. you turn it off, and a burst frequency of 52 per minute. So that's just one example to show you that there is an effect. So if we look at burst frequency, this is 14 patients. You can see, so this is 0, so this is the reduction in burst frequency. So you can see a mean reduction in burst frequency of about 13-14% here, which is highly significant. But you can also see that although there is a significant drop on the right, there's a trend, it's not as much. So there's a much bigger drop with left-sided stimulation. And unfortunately, I think it's just that the numbers aren't big enough here. We did a Mann-Whitney U test on this. If the numbers were bigger, I think we would have shown a significant difference between left and right. So what are we doing here? Well, here's our DRG lead. This is a picture that we just did for a journal article. And what you can see is that these are the afferent sympathetic pathways, and these are the efferent sympathetic pathways. And this is the sympathetic chain here. And these are the rami communicantes and the various ganglia. So, for example, L1, 2, 3, you would have the celiac plexus, for example, coming down here. I mean, it depends where you are. And so these autonomic fibers are all coming in through the DRG, and they're synapsing, and then we have these propriospinal fibers that join different levels. This is the efferent pathway here. So one of the things that we looked at was baroreceptor sensitivity. Now, if you remember your basic physiology, baroreceptor sensitivity is basically the body's way of controlling your beat-to-beat blood pressure. So as your blood pressure goes up, your carotid bodies expand because the blood pressure is higher. That increases neuronal firing into the brainstem, to the medulla, and then you have a reflex loop which then reduces your heart rate and your blood pressure. So you have a drop in sympathetic activity. Now, what we found was that when we measured baroreceptor sensitivity, there wasn't any change within an individual patient. So in other words, if they didn't have a significant baroreceptor sensitivity, that is a significant change of blood pressure compared to the heart rate, it didn't change with stimulation. And we had one patient who had a significant baroreceptor sensitivity that stayed significant. So our conclusion from this is that it's acting via a local mechanism. So in other words, it's not going up to the brainstem and the brain is saying, let's reduce the sympathetic activity. It seems to be happening in a local mechanism. And that would be very good if we were potentially to use this as a treatment, because it means we're not so likely to alter other things, like, for example, heart function, cardiac function, unless we stimulate at T1 or T2, which might be an interesting thing to try, I guess. Is it all related to pain? Because that's the big question. Are we just reducing pain and therefore reducing sympathetic activity? What you can see here is that there were some patients who, when they were off and on, the pain is on the left here. So if they're on the bottom, it means they haven't had a change in pain during the test. So we turn them off, and they haven't had time to have a change in their pain. It's still high or low. But you can still see that despite that, they still get a change in their burst incidence or their burst frequency. So they still get reduction in sympathetic activity without a change in pain, without pain relief. And there are one or two patients who had an increase in sympathetic activity. Those are the blue ones. Or overall, there's a reduction. So that started us thinking, well, what if this has a phenotypic advantage? What if we could control blood pressure with DRG stimulation? And so we looked at blood pressure in our patients pre and post. So this was baseline before they come in for surgery. They have 3 blood pressure recordings. And then at 6 months, when they came in for their 6-month check, we did another 3 and we averaged it. And we looked at all the patients. And this was a bit of a surprising result. We found that the blood pressure was significantly reduced after the DRG stimulation, but only on the left. So patients with left-sided stimulation had a significant reduction in long-term blood pressure, mean arterial pressure, and some of them had a huge reduction. So there's a big range here. But on the right, they didn't. And yet, the patients on the right still had pain relief. The pain relief was the same in both groups. But it seems to be that there is some asymmetry in autonomic control in the spinal cord. So the left-sided stimulation seems to reduce blood pressure and have a bigger effect on sympathetic nerve activity compared to the right. So what can we conclude from this? Well, we know that DRG is a good treatment for neuropathic pain, and that includes post-surgical pain. And we're particularly interested in these following groups. So hernia repair, joint replacement, surgical scar pain is another big thing, especially thoracic pain, and also any other conditions. We've treated some weird and wonderful conditions, neuralgia, paresthetica, and all sorts of things. And it seems that a secondary effect may be a reduction in sympathetic activity. I think this needs much further investigation in larger patient numbers. We need to look more at mechanisms. It seems to be that we've found an asymmetry in spinal autonomic reflex activity, but potentially may be able to look at other disorders such as hypertension. And our next plans are to set up a spontaneous hypertensive rat study and stimulate the DRG, because at the moment we've only stimulated it in patients with chronic pain. We haven't stimulated it in de novo cardiovascular patients. And obviously we need to do some further human studies to look at the effect of it.